Welcome to the Health 3.0 podcast, where the innovators who are shaping the future of healthcare bring you insights that help you take control of your health today. In our first episode, I want to talk about what's going on in our medical system. I want to talk about what's broken, or at least what's perceived to be broken in our system. And I also want to offer a potential future, a future that I call Health 3.0. There are so many great people who are building the future of our healthcare. Innovators, doctors, other healthcare practitioners, experts in AI, experts in tech, who are bringing us the future of healthcare, but many of you can't see it. So that's our goal in this podcast, is to bring these innovators, these providers, these experts in the space to the consumer so that we can provide a little bit of hope, a little bit of clarity, and help to bridge the gap between the conventional system and, again, this future that I call Health 3.0. So why do we need another podcast? There are so many voices to listen to, I hesitate to bring another one forward. But what we're missing in the podcast space, what we're missing with all of these voices, is a connection between the innovators, the people who are actually building what I hope will be the future of healthcare, and the audience of people who are consumers, the patients, the people who are looking for their health, for their care, for their information. What's happened over the last really several decades, but definitely over the last few years, is a disconnect, a lack of trust, a lack of blind faith, a disconnect between the consumer, the patient, and the medical system. So to understand my perspective on the healthcare system, I need to tell you a little bit about me. And I don't do this to be indulgent. I don't do this to put myself on a stage. But it's important when we hear people talk about what's broken or not broken, or what's working, not working, they understand who they are, what they've been exposed to, what they've gone through, and what their perspective could be in the situation. So I am a second-generation surgeon. I came from a medical family. My father was a cardiothoracic vascular surgeon, which isn't even a specialty today. I grew up in a household where we talked about mostly medicine. This is everything that I was exposed to. My mom was also a nurse. She worked with my dad in the hospital. So I grew up in the medical system, and I watched it as a child and then as a young adult. I watched it change through the 60s, the 70s, the 80s, the 90s until I got into medicine as an adult. But more than that, I actually got to see what it did to my family. I got to watch my father as he went from a solo private practice doc who was taking call at multiple hospitals, which means that he was called by multiple hospitals all the time, had a very challenging lifestyle. I saw how the rise of insurance changed his practice. I saw how Medicare and Medicaid grew and changed his practice and his lifestyle and our lifestyle. I actually got to the point as a young adult when he specifically told me, do not go into medicine. But when it was my turn to try to figure out what to do, because I didn't have any mentors in any other space, I didn't know where else to go other than to medical school. So I chose to go that route because I knew I needed to do something. I knew I needed to have a profession. I needed to make money. I needed to survive. And so I chose to go the route that my father went, and I went through medical school. Now, I didn't want to be exactly like my dad because, again, he had a really challenging lifestyle as a surgeon. I mentioned that he was cardiothoracic and vascular. That means heart. That means arteries. That means chest. And those are now three different subspecialties, all of which are still really challenging, and he did them all in one. But as I started getting educated through the medical system, which I'm going to talk a little bit about later, as I started getting educated, I realized that talking about drugs and trying to push patients into using something they didn't want to use wasn't really where I felt like I was going to provide the best value to both the system and to my patients. When I learned what could happen in the operating room, I got really interested in this definitive care, this very black and white, this is broke, I can fix it scenario that orthopedic surgery offers. So I went down that pathway. Also didn't hurt that it was a very competitive pathway. I'm a very competitive person. So I set my sights and my goal, my focus on being an orthopedic surgeon. So I did that. Went through medical school, went through residency, did a fellowship at Stanford, specifically in foot and ankle. And I went foot and ankle because I was very interested in the research piece of this. So the research side of this is very interesting to me. I wrote some studies and got some things published while I was in training. And that seemed to me like the future of, especially foot and ankle, because it had sort of been left behind in orthopedics. But it seemed like the future of orthopedics and all of medicine, because while there was a lot of evidence, we really needed more, we needed better, and it needed to come not only from universities, but also from private practice. So when I left my fellowship and I started private practice in Colorado, I was in a foot and ankle practice, but we were part of a research network where we were collecting data for research and still very involved in that, even though we were in private practice. In that scenario, I was part of the conventional system. I was in a traditional orthopedic practice, high volume, 50 to 70 patients per day. I had 2 PAs working with me. We were doing great work, having a lot of fun in the operating room, doing great surgeries. But right out of the gate, within the first really 1 to 2 years, I realized that the benefit that I thought that I was having for my patients wasn't really true. Yes, we were having successful surgeries and the outcomes were pretty good, but I felt like, especially in the foot and ankle world, so much of what we were doing was just cleaning up the metabolic mess that was left behind by bad decisions. Either bad decisions on the patient or bad recommendations by their provider or by somebody else. And there's so much disease and sickness that the bodies that were coming to me were not fixable in the ways and the tools that I had to fix them. At the same time, my wife, who is a PhD in nutrition, Dr. Ashley Lucas, started a company specific for weight loss through behavior, through nutrition. And she started seeing incredible results with just this simple nutrition. And in fact, I remember very clearly the first time we were sitting down at dinner and she said, "Oh, I reversed somebody's diabetes today." I said, "No, you didn't. You can't do that." And it turns out she was right, as she usually is. And it was the beginning of me understanding the power of nutrition, because as doctors, through medical school, we're taught a smidge of nutrition, but we're not taught to use nutrition as an intervention, as a tool. So my wife was using it as a tool, as an intervention, seeing tremendous impact, not only weight loss and maintenance of weight loss, but reversing chronic diseases, which I was taught is not possible. So put those two things together, I started realizing that I wanted to start talking more about other things. I wanted to start talking about nutrition, about exercise. I started learning about supplements. I started learning about all of these different things that I didn't learn about in medical school. So then as both my practice and her company grew, I started getting further and further away from where I wanted to be as I was forced to practice. I started trying to incorporate some of these things in, being kind of an integrative orthopedic surgeon. I was talking about nutrition. When my diabetic patients would come in with foot ulcers, I would talk to them about specific things in nutrition related to diabetes. I actually got told by my malpractice insurance company that I needed to stop talking about nutrition because I wasn't trained in it, which is arguably true, except that I was trained in it. They didn't even ask me what my training was. They just didn't want me talking about nutrition because really they wanted me to do more surgery. So I got very frustrated in the system. So I worked my way out before the pandemic to get some additional training. I realized that I wanted to treat patients in a different way. I wanted to help prevent disease. I wanted to help optimize people. And I wanted to use tools like what my wife was doing with nutrition, but even broader. Because I had the ability to learn about hormones, to learn about optimizing thyroid, to help people to function their best from an exercise perspective, but truly just from a life perspective, from a work perspective. I was starting to see the adults, my colleagues, in their 30s, in their 40s, falling apart around me. And I realized that we have this all wrong. So I left the conventional medical model. I worked part-time while I did an additional fellowship through the group A4M. I went into the space that some would call functional medicine or integrative medicine. I learned as much as I could about nutrition, about exercise, about peptides, about hormones. And I started a practice that was a telehealth practice because it was at the beginning of the pandemic. And it was called Optimal Human Health. Our goal was to help optimize anybody from any starting point. But very quickly, we started focusing on osteoporosis. And I'm going to do an entire thing on osteoporosis, so I'm not going to talk about that right now. But we realized that if we talk about the foundation, the building blocks of all of our behavior, the nutrition, the exercise, the mindset, the sleep, if we start there and then we optimize hormones and we do targeted supplementation, we can build programs that can help us to both prevent disease, but also reverse chronic disease, using a lot of tools, using very powerful tools that a lot of us are using anyway. We could just be using them better. Pretty quickly, that company grew, and then we attracted some attention, and eventually we got acquired by a larger company. So the company LifeMD, which this podcast is powered by, acquired my company Optimal Human Health with the goal that I would help them to build a women's health program, because I got very interested in hormone optimization for women post, peri, and premenopausal. Help them build a women's health program, or at least get it started. build a bone health vertical. And as I have gotten more used to the platform and understanding what the potential is here, to help them to realize the vision, which is to create an entire healthcare marketplace. A healthcare marketplace that can actually bridge the gap between the conventional medical model, what can be offered through telehealth. And then as I saw it, and as I started talking to the leaders of the group about, is how do we then actually bridge this gap into the functional side, the integrative side? How can we start pulling in all of these resources that people are looking for? And how do we put this in one place? And then how do we get insurance to pay for the parts of it that they can pay for? How do we get coverage through Medicare so that we can offer this to a much bigger population? What I saw is a vision of a different healthcare system. Again, a health system that I call Health 3.0. And let me just talk about that for a second. So I use the term Health 3.0 as how I see us bridging the gap between the conventional model and what we could be doing with healthcare. This comes from the term Medicine 3.0 that was coined, as far as I know, by Dr. Peter Attia. And if you haven't read his book called Outlive, I would encourage you to read that. He talks in depth about this term Medicine 3.0. But in short, essentially, he describes the first version of medicine to be kind of pre our current system, our conventional system. And again, I'm going to describe that in a second. And then Medicine 2.0 is the system that we all know right now, love it or hate it. Medicine 3.0, from Peter's perspective, is what comes next. And he has his practice that sounds amazing, and we're doing a lot of the same things, actually, and that's his vision. He calls it Medicine 3.0. I like the term Health 3.0 because I want to get away from the medicine, from the pharmacology. I want to talk about health because so much of what we do is outside of medicine. In fact, we're trying to avoid medicine. So I understand what he's saying. I'm not saying he's saying it wrong. I just like the term Health 3.0 because it gets to the root of what we're looking for, which is health. So then to understand where we want to go, we have to understand where we started. So let me go back to, again, what Peter calls Medicine 1.0. I'm going to refer to it as kind of pre our current medical system. So again, a lot of people think that the medical system is broken. I'm going to show you why the medical system actually isn't broken. It's just outdated. So to understand our current medical system, we need to actually go back to the early 1900s. Before medical schools were what they are now, before medical research what it is now, before the pharmaceutical industry, before the insurance industry. We have to go all the way back to early 1900s, before then, when doctors weren't very well trained. Essentially, to be a doctor, you had to find a mentor and you were an apprentice and you learned some kind of handful of tools, hopefully, that you had to treat the few things that we had the capacity to treat back then. This was a big issue because there wasn't much technology. They didn't have many tools, and the evidence was really poor, right? Again, it was just somebody's experience passed down to a handful of other people, but they were not connected. So there were some key time points like the Rockefeller Institute for Medical Research in the early 1900s, the Flexner Report in 1910, a lot of push to bring together resources, money, and creating a unified medical education system, which was a great idea. I've heard some people say that this was done with this, this malintent, this malicious intent to create a business model. And I don't know if that's true or not. Certainly became a business model. But early on, this was needed. We needed better education. We needed unification of all the information that was out there. So it was a good thing. And there was a creation for standardized science-driven medical education and science-driven research. So now there was put into place this idea that we could do research that could then educate the physicians, and then something would happen as a result of that. There was legislation that went along with that for the subsequent following decades. And then the research really started to take off, and you started getting inventions like antibiotics, right? We started understanding how we can treat acute diseases. And this is a really important point. So when I say acute versus chronic, what I mean is acute would be things that are going to generally kill you quickly, like an out-of-control infection, trauma, right? These are the things, death from childbirth. Like these are the things that killed most people in the early 1900s. Whereas today we have a chronic disease-driven medical system where we're not dying from the things that the system was designed to fix in the first place. Now we have more chronic disease because we were successful in treating and figuring out how to treat the things that were killing us in the early 1900s. The research led to the idea that we could create individual molecules. We could create drugs rather than using the natural solutions that may or may not have been working at the time. The pharmaceutical industry then was born and was really built into the system of research, into the system of academia, into the system of medical education, and then you created this loop. So now you have a loop where the research is being done on a specific issue, likely some kind of drug is being created out of it, educating doctors about that opportunity, that tool, and then the doctors are giving that down to the patients. So now we have this complete loop. And that actually worked, again, in the short term because we were treating things that worked well in that situation. So this is acute care healthcare. We were so successful that the life expectancy started to increase. And then, over the course of the next several decades, get closer to where we are now, you start to see the rise of chronic disease. So if you go back to the 60s, really 50s, 60s, 70s, 80s, you started to see heart disease take off, right? And then you got into the research around Ancel Keys and saturated fat and cholesterol. And this whole new world where we're realizing, oh, we're living long enough to die from something else, to die of a heart attack, to die of Alzheimer's, to die of some other form of dementia, to die of osteoporosis, of fragility. And then we're asking the same system to take care of those things. And this is why people say the system's broken, because when you ask the system that was designed for something else to take care of these chronic problems and it can't do it, you say, the system's broken. The system's not broken. The system is actually working really well for what it's designed to do. You could argue about whether or not it's too expensive, but it does actually work. And I'll give you a great example. I almost couldn't come record today because yesterday my wife woke up with really terrible stomach pain. She was having an acute appendicitis, meaning her appendix, which is a little organ off the colon, was inflamed, causing her severe pain. So I rushed her to the emergency room. Within minutes, we were in the hospital, CT scan done, problem identified, having a discussion with the surgeon about what to do about it. That is the system. If you were to have a heart attack, you could be in the cath lab within minutes of hitting the door of the emergency room. If you were to be in a bad car accident, you could be in the operating room within minutes of hitting the trauma bay. The system can do some amazing things, but what it doesn't do well is to prevent heart attacks, to prevent fragility fractures, to prevent Alzheimer's, because it's just not designed for that. Now, fortunately, my wife is doing great. She's at home. I'm here. I'm able to talk about these things, but it was such a great reminder as I was thinking about what to say in this podcast. Man, I'm glad we had a hospital nearby because it really potentially saved her life. The result of our success in creating a system that is good at treating things that allow us to live longer is that we now have a system that isn't doing a good job for the things that are actually bothering us and killing us. In the United States, we have the most expensive healthcare in the world, and yet we have some of the worst health outcomes in the globe, including some not very modernized countries. So over the last several years, as I've worked my way out of the conventional medical model, I have spent time seeing a very dim future of the healthcare system because I recognize that it's not good at doing the things that most of my patients need. But yet I also see a really bright future because over these last several years, I have met some brilliant doctors, brilliant innovators, amazing tech, the birth of AI and what AI can do in the healthcare system. We actually have a really bright future if we can harness it in the right way. But this potential bright future is in jeopardy. It's in jeopardy because over the last several years, especially, but over the last several decades, we have lost trust as consumers in the healthcare system. It used to be that people would go to their doctor and whatever their doctor said, they believed. Well, doctors have lost that trust for lots of reasons I'm not going to get into. Some of them good, some of them bad. But doctors have lost the trust. Hospital systems have lost the trust. Insurance companies, if they ever had it, have lost that trust. People are looking for their own answers. People are online, they're on Instagram, they're on Facebook, they're looking on YouTube. They are consuming a tremendous amount of content. And that is both good, it's also potentially bad. Now every patient that comes in the door has asked Dr. Google what's wrong with them and what do they do about it. Now they're asking ChatGPT, what's wrong with me? What do my labs mean? What should I do about it? So we have ultra-educated consumers, which again is good, except that it's in a very uncontrolled environment. So now the doctors are actually fighting an uphill battle to try to impart to their patients what the available evidence shows. And they're actually trying to encourage them to do something that they think is going to be good for them. And a lot of times they're actually losing that battle. Sometimes it's a good thing for the patient, but sometimes it's not. So now we're in a really unique space We need to come together as both providers in the conventional space and consumers who are looking and desperate and hungry for this information and come together in the middle. And what I think that middle is not getting rid of the conventional medical model. We don't want to disband this. We don't want to throw it away because, again, it just saved my wife yesterday. But we do have to understand that there are areas that do not fit in the conventional model. I told you that I went through the functional medicine or integrative medicine pathways. I learned so much interesting information, and some of that information is really helpful, and I love it. But some of it's not, and some of it's being touted as the answer when the evidence doesn't support that. So how can we as providers in the conventional space, people who are great in the functional space, technology that's great in the functional space, in the integrative space, how can we come together and create an ecosystem, create a marketplace where the best of what's out there is available, and we can educate people to look for the things that they're passionate about, that they think that they need, and that we can help guide them to find the answers that they're looking for autonomously, independently, and safely. And this is the creation of, again, what I call Health 3.0. Because I want people to be consumers. I want them to do the research. I want them to come into my office, to walk into my now virtual office room, and have a conversation based off of what their concerns are, already having watched videos, already having learned from other doctors, so that we can have a real, transparent conversation about risks, benefits. We can have true shared decision-making when it comes to choosing some kind of an intervention, whether it be a drug, a surgery, a supplement, or something foundational like nutrition or exercise. This is Health 3.0, where we have a marketplace of options. We have tools that can bridge from conventional to functional to integrative, all the way over to lifestyle, right? We have all of these tools at our disposal. Insurance hopefully will cover the pieces that we want it to cover. We can get Medicare on board to cover the things that we think are going to be helpful for preventing disease, which is ultimately our goal, right? I'm a big fan of this concept of health span. How long can you live a healthy life? Much more so than the lifespan, right? Lifespan is just how long we live. I don't want to live a long life if half of it's miserable. I've seen my patients do that. I've seen my patients live till 80, 90, 100 years old, but at 50, their health fell apart, and they spent decades in misery. I don't want that kind of lifespan. What I want is a health span where I live as healthy as I can for as long as I can, and then I either literally or figuratively drop off a cliff. To do that, though, we need to prevent chronic disease. Because again, most of us are not going to die of trauma, are not going to die of an infection. Most of us are going to live to experience some kind of chronic disease. So then we need to early on be screening the way that we can screen. We need to be educating about what our diet, what our exercise or lack thereof is doing for cardiovascular risk, our hearts, our lungs, our bones, and then prevent these chronic diseases for as long as possible. To do that requires participation, it requires education, and it requires action. And my goal is that our Health 3.0 that we can build as a community of innovators, of healthcare providers, of tech, and consumers, we can provide all of these resources to people, and together we can go from Medicine 2.0 to Health 3.0. So I think I'll stop there. I think I got the point across. I'll just end with this. I really believe that we are here to make memories. We are here to acquire memories, to experience life. To do that, we need to age with strength and grace.